Thank you very much, John. And thank you, Janet, for that wonderful talk. Um, while you were talking, when you were reading out the list of crimes and things that weren't done, I was finding myself getting angrier and angrier. You forget all the things they did and all the things they didn't do. So I'm very pleased that we've got this conference. It's wonderful how we've all come together, and especially pleased that so many people have turned up today, because I think it reflects an understanding and an appreciation that we've got to come together and fight for protections. They are not going to give it to us. We know that. And as there's this saying that I learned recently, we are the people we've been waiting for to bring about change. So it's down to us. Okay, so I'm going to share my screen and just go through a few slides. I'm sorry if there's a noise in the background. The doorbell has just gone, but I'm going to ignore it. Where are we? Share that one. Yep. Hold on. Okay, can everyone see that all right? Don't know why it's going to that smile. There we go. Okay, so why infection prevention and control really matters. As Jonas said, it's kind of set the tone, well, not kind of, it set the tone for the entire approach to the pandemic. And not surprisingly, because you would think that, this is a disease and healthcare needs to get it right, and that will provide a lead for the rest of the country. But as we all know, it got it disastrously wrong. And not surprisingly, the country's response to the pandemic has also been disastrous. Yeah, so that's who I am. There's an email address if you want to email me, please do. So just to go back to basics and the science, and apologies if some people have seen these slides before, but as Jonas said, we must keep on saying this thing is airborne. We heard at the inquiry this week and last week that the dinosaurs who are in control of things still say it's not. So, two types of airborne spread, near field and far field. The risks are high here, 1 to 1, but the risk of super spreading and the super spreading events have been the thing that have been driving this pandemic and why it's kept going. And this is one of many, many scientific papers that makes that point, that super spreading is the driving influence of pandemics. So many people think, and the authorities have led us to believe, that COVID spreads like this, 1 to 1 to 1 to 1, or 1 to 2, 1 to 3, but it's not. It's this cluster type pattern. We have one infection leading to 10 or 12, and then each one of those people can set off their own clusters, or 1 or 2 other people, say in the household, and so on. So it's like that, excuse me, that awful weapon they still use in war, a cluster bomb, one main device, which then releases a whole number of others, and then they explode. And I'll just go through some of the famous, if you like, epidemiological studies, most of which were done early in the pandemic, to show how super spreading works and how deadly and how it explains the exponential spread. You remember those curves in the beginning and the R number and all of that? Well, that didn't really convey it, but I'm sure you remember those graph lines that were vertical almost. And the reason for it is this. So this is the call center in Seoul. 1 or 2 infected individuals, who are the colored blocks here, infected almost the whole workspace in this call center. This is the Northampton Green Core factory outbreak in August 2020. They make sandwiches for M&S. Typical super spreading event where over 300 workers were infected within a few days of each other. And of course, the management blamed the workers, and shamefully, the local director of public health agreed with them. This is a study in schools in China. It's quite a complicated study, but very well done. They gave all the kids a little device to wear to track how close they were to each other. And then they mapped the pattern of infection. And the central conclusion of the study was that long range transmission dominated. It's not close up, although you're most at risk close up, in terms of numbers and spread and transmission through communities, it's the long range route that is dominant. There's another study from schools. This is in Seoul. This was a kindergarten, I think, and a taekwondo class. And again, you see that super spreading pattern, that cluster pattern of spread. This is emphasizing the importance of children as vectors for the transmission, as one of the main drivers for transmission. And Janet has alluded to that as well. This is a big study in the US that showed that 70% of households who got COVID, the kids brought it home from school. They were the kids with the index case. This is another study in France that showed similar things. In other words, that the kids were the main spreaders of the disease. Not surprisingly, they spent 6 or 8 hours in the same classrooms in close contact with lots of other people. This graphic I really like. This is MERS, which is a different coronavirus. And this happened in 2015 in Korea. And these are all the super spreading events, right? The index case for this particular spread was there. But look at this chap here. He went to an emergency room in a different hospital and spent about 36 hours there. He infected over 80 people. About 15 of them died, both staff and patients. So that's what coronaviruses can do when there are favorable super spreading conditions. But we ignored that, of course. So just to go over what are the risks for spread, and it's worth bearing these in mind. Transmission depends on the number of people in the space, how much COVID is around. So if there's, 1 in 200 people have got COVID, your chances of getting COVID in a tube carriage or something like that is not that big if there's 20 people. But if the rate is 1 in 30, you may well get it. What people are doing, because we know heavy breathing, shouting, singing, lots of aerosols, the size of the space, and time in the space is very important. And that's why going back to workplaces, schools, hospitals, and so on, that's where we spend most of our day, 8, 10 hours a day there. Not 20 minutes in the supermarket. You could get it in the supermarket, but it's much more likely you get it in the congregate space where you spend long periods of time with the same people. And then, of course, what mitigation measures are in place. So when you hear this mantra, oh, you got it in the community, everybody always gets it in the community. That's not correct. The chances are you've got it in your workplaces, in congregate settings, like the places listed down the right there. Now, the other part of the science, so that's the science of transmission, right? The other part of the science is the protections that we have to mitigate and reduce transmission. They work, okay? And we've heard this dreadful, destructive, and nihilistic narrative from the authorities that, oh, they don't really work anyway. This week we had Susan Hopkins, who's the clinical director or chief medical advisor of UK HSA, saying there's no difference between surgical and FFP3 masks. So this is a study done early on in the pandemic, which showed ICU staff wore FFP3s. They had a 15% infection rate. Everybody else had surgical masks. They had more than double that. The bar in red is housekeeping staff, right? Porters, cleaners, catering staff, and so on. They had the highest rates of all. So that shows you airborne risk is everywhere. You can't have situational high risk. The air obviously travels everywhere in hospitals. And the other point about the study, it showed that Black and Asian healthcare workers had double the rate of white workers. It's all about exposure. And we're going to hear more about that tomorrow. The other, one of the other main protections, air filters, they too work, okay, despite disparaging comments from people in power and authority. Jose Luis Jimenez, one of the world famous aerosol scientists, people are probably familiar with his work. This is a really great video to watch if you want to understand about air filters. He says 2/3 of transmission can be reduced by cleaning the air. And ventilation, we all know ventilation works, but here's the evidence. This is a study in schools. The greater the rate of ventilation, the less the relative risk. Note that the curve flattens at the end, doesn't get rid of all of it, but I think the figure down here is about 80% in a well-ventilated space. So that's the science, right? How it spreads and what we can do about it. And these things work, and they're actually not that expensive. There are other devices like UV light and so on, but for the practical purposes, these are the things that we have at our disposal. Now, coming to the guidance. We're following the guidance. Aren't you sick and tired of hearing about that? We're following the guidance like a mantra, like we pray to it. What the National Infection Prevention and Control Manual says, it's evidence-based. Yes, it's evidence-based. It's mandatory. They've made it mandatory, and they have actually now assumed the role of the regulator in the workplace. I'll come back to that because HSE has been completely AWOL, and it applies to all care settings. There have been 54 versions of the IPC guidance since January 2020. That initial guidance said there's a precautionary principle, as Janet has said, to protect us when don't know, we're not sure about the methods of spread. They ditched that when they ditched the HCID, the high consequence infectious disease status. There are 12 appendixes in that guidance. 4 of them talk about hand washing. There is nothing about air filtration or ventilation. So the IP guidance is still droplets. If you want to read why this is complete rubbish, read the Delphi consensus statement and the mountains of evidence about it being airborne. AGPs, the other plank of current policy, also rubbish. The aerator study, the Lancet editorial, and so on. And you can click on those links and see the evidence for yourselves. It's not a seasonal virus. They keep saying, not yet, not yet. That wishful thinking. Science doesn't work like that. It doesn't matter how much you wish something is something else. It's just not a seasonal virus. And I'll show you another slide shortly to show that. And then what it leads to is this nihilism, as I've mentioned. We can't stop transmission, so there's no point in trying. This is another very good paper led by Jimenez, which analyzed the reasons why the IPC scientists and public health doctors in power and authority just refuse to do anything about it. It's a fascinating read. And I've put up all the authors here just to show you who they are. I mean, these are the people who've basically given us the understanding of how transmission works. Jimenez, Lindsay Ma, Lydia Moravska, I'm sure you know some of these names, William Barnfleth, Kimberly Prather, Julian Tang, and so on and so forth. As I say, all the rock stars of aerosol transmission. It's not a seasonal disease, right? The blue lines on the graph are flu. That's a seasonal illness. Every winter, we know that. The red line is COVID, the massive peak at the beginning, and then several peaks and waves throughout the years, right? And there's another slide in a minute to underline that. But I want you to look here. See the blue line? There's nothing there. There's nothing there for flu because there was no flu in that winter. Why? Because we were wearing protections. Lots of people were wearing masks. We were actually caring about this disease and this virus. It didn't actually eradicate COVID because COVID is more infectious than flu, but it eradicated flu. Flu kills 15,000 people every winter. If we put in airborne protections, setting aside COVID, we could get rid of 15,000 deaths a year. This slide shows that. But no, no, no. We've got to go back to no masks, no protections, and so on, because it's not convenient for the business model that we live under. This is a more up-to-date slide. This is, again, hospital admissions showing the winter peak, the May peak, and the summer peak. And I think, Joan, you said there's another peak on the way now yet again. So this is not a seasonal virus. So we've dismantled basically all the protections we had in place. I won't go through all the detail. You can read it for yourself. But mask wearing in the hospital is almost non-existent now. It's optional. We've abandoned testing other than people who have symptoms in hospital. Sick leave for health and social care staff has been done away with. So workers are paying the cost for this new disease, for the sick leave that they negotiated in their contracts pre-pandemic. There's no extra allowance for a pandemic they're not protecting workers against now, but they pay for it. The isolation period of 5 days, absolute made-up rubbish, ignores the science. The ONS infection survey is gone. We had the very weak and unreliable winter COVID infection survey. It gave us some information, but they stop it in March. Because why? Because they've declared it seasonal. The genomic sequencing is greatly reduced. We were great at doing this. We were really good at it and contributed to the world effort against this. But now it's been so scaled back that there's very little going on. The vaccine program, greatly restricted. We should all be vaccinated. We're all at risk. And wastewater surveillance, they're messing about with it in Scotland, not reporting it properly. They stopped it in Wales, and it's never been in place in England. So all the tools of monitoring, testing, giving people time off work to get better, and so on, chucked out the window. Just on the isolation period, here's 5 days. Sorry, where's my cursor there? This is the risk, okay? So no matter what Delta Airlines demanded of the CDC, which changed the rules to 5 days, this is the science. That's why we need 8 to 10 days to get better. So that's my view of what infection prevention and control policy is. I think it's quite apt. So what are the consequences of this poor policy, right? That's disaster. This is a graph of hospital-acquired infections, so-called nosocomial infection. 30%, and this was at the middle of 2023, when the chap doing this graph had to stop collecting the data because it became so unreliable. 30% of people who have COVID in hospital got it in the hospital. That is a disaster in terms of infection control. There's the other consequences. Now, these figures are old, right? Probably a couple of years old now, maybe 18 months old. 2,100 healthcare and social care workers have died in the first 2 years. There you go. 200,000 healthcare workers have long COVID. Again, a rather old figure. It's more now. 40,000 people died in care homes. At least 14,000 people died of hospital-acquired infections, and 70,000 people caught the virus. This is a Daily Mirror article, I think in late 2022. So this is the result of a fundamentally flawed IPC policy. So these are the villains, okay? Lisa Ritchie at the inquiry 2 weeks ago. Droplets and AGPs remains our policy. Susan Hopkins, Chief Medical Advisor, UKHSA. Droplets and AGPs remain our policy. I'll come to Hancock in a minute. Professor Chris Whitty, saying everything to please everybody. Ventilation's important. FFP3s, however, are complicated. I'm not an IPC expert, and the IP cell is responsible for policy. Whereas Ritchie said, when she gave her evidence, ultimately they're not responsible. It's Whitty and his colleagues in the senior clinical decision-making group. And then we come to our friend Matt Hancock, who said at his inquiry evidence that, this is in December last year, he knew in early summer 2020 that airborne transmission was more important than droplets. What did he do as the health minister, the ultimate person responsible? Nothing to change the policy. They all did nothing. And here we have Sarah Albon, chief executive of the HSC, saying there's nothing wrong with IPC guidance. And in fact, completely abrogated the HSC's responsibility and handed over to these people in IPC to protect workers in healthcare and health and social care. Completely illegal and inappropriate. So what happens in hospitals is really, really important because, as I said, it determines the overall approach that we've taken as a country to what goes on. And it's allowed employers, managers, and others, and the bad actors and the naysayers who say, oh, they don't do it in hospitals, so why should we do it? There's no need. And you get in the community anyway, and we can't stop transmission, so what's the point? So what can we do about it, both as health and social care workers and workers generally, and as members of the community and patients? I mean, we'll talk a lot about this in the rest of the conference, obviously, but the Health and Safety at Work Act gives us the legal right and the places a duty on employers to provide safe working conditions. And Regulation 6 of the regulations says that every enclosed workspace must be ventilated by a sufficient amount to give you fresh and purified air. I've spoken about HSE and IPC. In terms of patients and members of the community, this is some information on the COVID Pledge website about how you can challenge poor practice in the workplace, sorry, in hospitals and GP surgeries and so on. Lots of resources here about letters and so on, which you can write in. And it gives you a lot of background about the IPC guidance. So if people say to you they're following the guidance, there's a lot you can do to challenge it. But remember, to challenge things, do it on your own, but get together with other people. And that's one of the main ideas and motivators of this conference, is that by coming together, we're stronger together. And if you do things in groups and in campaigns and so on, you're much more likely to be effective. Okay, I'll stop there. Thanks very much.